PCOS? Well, there are many and varied, and the main reason for them is due to the raised serum androgens, which are our blood hormones, which are male-like, if you like. And this,
sorry. Oh, don't do a look. Is that outside?
Yeah, it's not outside.
March outside.
So these are the male-like hormones, which are testosterone and LH. We've already heard that LH is raised in a lot of patients with PCOS, and this has a male-like effect on the skin, which causes problems such as acne, hirsutism, which is too much hair, androgenetic alopecia, or male pattern baldness, which is too little hair. But you also heard from our previous speaker, and probably earlier in the day, that it's not just about sex hormone access that's abnormal in PCOS. We also have problems with our insulin resistance, and that metabolism. And insulin resistance leads to other problems that affect the skin, such as obesity. And
I think it's actually a march. It's a march outside, sorry.
Oh, can everybody hear me?
Yeah.
But also a risk of something called hidradenitis suppurativa, which I'll go into in detail in a little bit, and another skin condition called acanthosis nigricans. So our skin problems are due both to the increase in male hormone, but also to the fact that we've got insulin resistance. What's interesting also is at what age these features present. And you can see from this slide here that the majority of patients present with skin problems, and indeed with most features of PCOS, between the ages of 26 to 34. A few patients will present before the age of 20, but very few. And then as people get older, actually the number of patients presenting with this gets diminished. So first of all, let's deal with hirsutism, or increased hair growth. And the definition of hirsutism is that it's hair outside the normal female pattern. So we're talking about the beard area of the face, the chest, particularly around the nipples, the central chest, the stomach, particularly encroaching up into the midline and around the tummy button, and the thighs. But the hairs also are thick. They're what we call terminal hairs. They're thick and dark. They're not soft and downy, or what we call vellus hairs. But this is complicated by the fact that hair growth isn't the same in all women anyway. There are other factors which change the way we grow hair. Some women are just hairier than others. There are racial factors. So Asian women are much hairier than, for example, Japanese women who have no hair at all. And there are also social factors. So a woman who's born in India will be used to the fact that her family all have very hairy arms, very often hairs on the abdomen, but that's not socially acceptable in this country, and therefore they're under then pressure because they feel they shouldn't be so hairy. So there's lots of factors as to what makes a diagnosis of hirsutism and what is actually normal hair growth. This is an example of somebody who has increased hair on the lower back, and as you can see, quite dramatic hair growing up the abdomen and into the lower abdomen here. This would be classed as hirsutism. When we see somebody who's complaining of increased hair growth, we use various grades that are standardised so that doctors can put an objective assessment on this, and this is called the Ferriman-Gallwey assessment. And you can see that it varies, each sort of site you can have 4 different levels of. So you can have a little bit of hair on the upper lip to a full moustache. You can have a little bit of hair on the lower arms going to really quite furry arms. And the same on the legs, a little bit of hair on the upper thighs, which is actually normal, extending to really, really quite dense hair growth on the whole legs. And what we can do is we can do a score, and that's very useful then if we're instituting treatment to see whether there's actually an objective response. So what causes hirsutism? Well, male sex hormones are the most common cause. And you can get male sex hormones from various places. You can get them from the ovary, you can get them because you're overweight, the adrenal gland also leads to androgens, various drugs can cause problems, or it can just be you. Between 60 to 90% who have an ovarian cause of hirsutism, it's due to PCOS. Very rarely it's due to a tumour. Obesity quite often leads to increased hair growth, and that is because there is a protein called sex hormone binding globulin that is stored in fat or accumulated in fat, and therefore it's not released in high levels in the bloodstream, and therefore you have free testosterone because it's not bound to this protein anymore, and therefore it acts to increase the amount of hair. And this is why weight loss is so important in the management of hirsutism. Adrenal causes of hirsutism, again, are rare, but we would always look for them if we get a history of sudden onset of rapid hair growth. Various drugs can cause hair growth, and importantly here is the oral contraceptive pill. So some women can be put on the oral contraceptive pill to manage their cycles, but actually it's one that can make them hairier. So that's the first place I will often look to make sure we're not putting patients on a drug that's going to make matters worse. There are other drugs as well that can also increase problem with hair growth, such as anticonvulsants, particularly a drug called phenytoin, oral steroids, and an immunosuppressant called cyclosporine. This is due to use of drugs in sports, which can cause the same problem. So if I'm faced with a patient with hirsutism, where do I go in terms of investigating them? What's the clinical evaluation? Well, what we've got to do is work out whether it's actually coming from the ovary, from the adrenal gland, or it's just normal. So we do an FSH and LH, testosterone and other male hormones, an ultrasound to see if there's a problem with the ovaries or with the adrenal glands, and other hormone tests to see if there may be a problem with the adrenal glands. And this will guide us as to whether it's PCOS, whether it's normal, or whether it may be an adrenal cause or Cushing's syndrome. And any patient presenting with rapid onset of a change in hair growth should go through this gamut of investigations. And this can often be done by a GP, can be done by an endocrinologist or a dermatologist. So a diagnosis has been made, and obviously for this forum, what we're most often looking at is a diagnosis of polycystic ovarian syndrome. So what do we do about it? Well, the first thing is simple physical methods of hair removal. And we don't like waxing or plucking. And the reason for this is if you wax or pluck, it does convert vellus hairs into thicker, more terminal hairs. And also it can inflame the hair follicle that can then lead to problems like acne or folliculitis. We also can cause problems with hairs ingrowing. So we discourage waxing or plucking. Shaving is something that most women are used to doing, the hair on their legs or on their arms, but there's a huge psychological barrier, understandably, telling a woman to shave the face. But nevertheless, that is one of the best ways to get rid of hair on the face without causing a problem in terms of ingrowing hairs or transformation to terminal hairs. Bleaching is also a very effective method, and depilatory creams can also be used. What about permanent methods of hair removal? Well, there is no such thing. And the reason for this is the hairs grow in a cycle. So any method of treatment that destroys all the hairs at that time won't be destroying the hairs that are in their embryonic phase, if you like, that are still yet to grow. But if you keep having courses of electrolysis or laser, eventually you will get to a stage where there are very few hair follicles left, and therefore any regrowth will be less. But that's why when the patients are having either electrolysis or laser, we advise to use a physical method at the same time. And what we will notice is the number of cycles you're having to have electrolysis or laser get reduced. Electrolysis, you've got to make sure you're seeing somebody reputable. And I always recommend people go to the British Institute of Electrolysis. They will be able to give you the addresses of the recognised electrolysis in your area, not some cowboy who's just set up in a corner street. There are two different forms of electrolysis, either galvanic, which is a chemical reaction with tissue salts, which is very good for people who have darker skin. The problem is it distorts the hair follicles, and therefore you can get inflammation. There is less regrowth, but it's very slow. Diathermic electrolysis is one that's more commonly available and relies on heat, and it's very good for very fine or shallow hairs. But the problem is you get more regrowth, and also because it's heat dependent, can burn the skin, and that, particularly people with darker skins, can lead to quite nasty pigmented scarring. Another option is laser, and there are various lasers that are available, and I'm not a laser specialist, so I won't go into this in particular detail, but there are several different lasers, all using different wavelengths. But the main problem is the laser is picking up the difference in the pigment between the hair and the skin. So if you have pale hairs and pale skin, or dark hairs and dark skin, you're going to damage the skin. This is much better for people who have dark hair and pale skin, where that contrast is very obvious. There's also IPL or epilite. The problem with that is it can have quite nasty side effects. There are also prescribed treatments. I don't know how many of you have heard of Banneker or Eflornithine. Okay? So this kind of revolutionised the way we could treat hirsutism. And it's very good because it works on the enzyme level that stops conversion of the testosterone into an active form that works in the skin. And it reduces, therefore, the rate of hair growth. But you use it with other methods. So you can use it with laser, you can use it with electrolysis, you can use it with shaving. The most important thing is you need 5 minutes in between application of the cream and using all of these other methods, otherwise you get irritation. You have to use it for at least 8 weeks to know whether it's going to work. And if it hasn't worked after 8 weeks, there's no point in persevering with it. But if it's not worked after 4 months, I would definitely stop it. But you won't see anything up to until 8 weeks have passed. The main problem I have, because I also have an interest in acne, is it causes acne quite a lot of the time. And I would say that that's the rate limiting step with this. And of course, as you will hear later on, patients with PCOS have a tendency to acne as well as hirsutism. And for me, I think this is the biggest problem that we have with acne. It is sometimes prescribed on the NHS, but not always. And if it's on a private prescription, it's about £75 for 2 months, so it's not cheap. Other prescribed treatments are metformin, and we've heard about metformin earlier today. And so this is working on the insulin resistance pathway. And it's particularly good for people who have anorexia cycles and are overweight, but it is particularly good in this situation for hirsutism. Anti-androgens, I've already said, hirsutism is due to the increased androgens in the skin, so why can't we reduce them? Well, that's one of the reasons why we use pills, combined pills such as Dianet, which has an anti-androgen, but also the less androgenic pills such as Cerazette or Yasmin. The anti-androgens we use are called spironolactone, which is actually a diuretic or a water tablet that was noticed as a coincidental side effect to reduce hair growth. And that can be limited by its side effects again, so weight gain, breast tenderness, headaches, and finasteride, which is another anti-androgen. And these are both very good if you've got acne as well, because they will help treating the acne. Any questions about hirsutism before I move on? Okay. So the opposite end of the spectrum is androgenetic alopecia, and you may well be thinking, well, how come in one instance you can get too much hair growth, but now we're going to be talking about having too little hair growth? And this is because if you think about where men grow their hair, this is all very hormone dependent. So the hair receptors do different things at different sites of the body in response to the male hormone. So you grow hairs where men will grow hairs, so in the beard area, etc. But also men go bald before women do, and that's also under the action of the male hormone. And so women with too much testosterone or with too much sensitivity to testosterone can get the same problem, and you can get early male pattern balding. So you can get this without actually having an androgen excess. All women will get a little bit of thinning, what's called the widow's peak anyway. But what can happen is people with PCOS or other hormone imbalances can get this a lot earlier. You could also get this as a late onset phenomenon post-menopause. And again, that can be with a hormone imbalance or without a hormone imbalance. Another reason why you can get alopecia is due to thyroid abnormalities, and this also needs to be excluded, as well as iron. And one of the problems I often see is people have their serum iron measured or their ferritin measured, and it's normal. But there is a very wide range of normal, which is between 25 and 200. And we know that if you have levels less than 75, which is strictly speaking normal, it can be associated with hair loss. So if you do have your iron, if you are suffering from hair loss, and you do have your iron levels measured by your GP and they're normal, just check whether they're normal low or whether they're normal high. Because if they're normal but less than 75, you would still benefit from an iron supplement. One of the treatments that we can use for androgenetic alopecia is topical minoxidil. This again is a drug side effect, if you like. Minoxidil is a drug used for high blood pressure, but as a side effect, it was noted that it caused hair regrowth in balding men, and now we use it topically on the skin. It's called Regain. Some of you may have seen this. The downside of Regain is it doesn't actually lead to any significant useful hair growth, but what it does is it stops you losing any more. So if you notice you're getting thinning on the top of your scalp and it's androgenetic alopecia confirmed by a doctor, using this can stop it getting any worse, but it doesn't suddenly give you a nice flourish of new hair growth. Anti-androgens can also be helpful, as can insulin sensitizers such as metformin. And again, in the same way as we use the Crown Galway system to measure hirsutism, we use Ludwig's scale to measure androgenetic alopecia. And the first way that it starts is with a little bit of widening of the parting, and then this becomes more obvious until you actually get frank baldness there into the male pattern. And the other thing that can happen is rather than it being just a widow's peak, you can get frontal recession. So those are the two patterns of hair loss that you can see in there. So the third thing that I want to discuss in more detail is acne. And of course, a lot of people can get acne that's not related to PCOS at all. So just dealing generally with acne, what is it? Well, it's a disorder of the pilosebaceous glands. These are the fatty glands that you get predominantly on the face. But you can also get them on the back and chest, so people can also get acne in these areas as well. And this is an illustration of the pilosebaceous gland. This is where the hair grows out of, and these are the sebaceous or fatty glands here. And normally, you can see this is looking very like some of the slides we saw before. The sebaceous glands are under the influence of hormones, and so it's kind of a bit blurred, but coming out of the influence of hormones secreted in the pituitary gland again. So the sebaceous glands are under hormonal control, and as puberty kicks in and the hormone cycle starts developing, acne starts at this time, and it's particularly linked to the circulating androgens. So boys tend to get worse acne than girls. Women tend to get acne particularly around the time of their period, because as we remember from the previous talk, what happens is that the levels of hormone fall, which is what allows you to have your period, so the body sees, although not in reality, a relative increase in the male hormone, and that's why you get spots just before the time of your period. This acne is a particular problem that we see in polycystic ovarian syndrome. What happens is, rather than there being a nice clean duct for the grease from the pilosebaceous gland to come out onto the surface of the skin, you get sticky cells, which we call keratinocytes, and you get this little plug developing in the duct, and therefore the grease can't actually make its way up anymore, and it just gets thickened and blocked in this duct. And that then leads to inflammation. And this slide shows microconodomas or blackheads as we would know them. And you can see this patient has sheets of these blackheads, which have become much more of a problem. What you then get, though, because of this blockage within the glands, is you get inflammation. You get cells that shouldn't be here all around the pilosebaceous gland, causing inflammation. And that then leads on the skin to redness and pustules. What we also know in patients who have acne is they have a high grease secretion, and this has been measured by using a sticky tape that you can apply onto the face and then weighing it. And we know that people who have acne have higher sebum secretion. We know that they have a higher level of blackhead formation. We know that sebum then gets stuck within the duct, leading to inflammation, and then these pustules and papules. And this is again showing the grading system that we have for acne. So you start off with leads grade 1, it then builds up to more inflammatory lesions to leads grade 3. You then get nasty nodules, the leads grade 6, and then really very severe acne. And unfortunately, this can lead to scarring. This is usually when those thick, inflamed lesions burst underneath the skin, and it can lead to scar formation. And you can get pitted or chickenpox-like scars, you can get deeper scars, you can get keloid or hypertrophic scars. And this is what I'm trying to avoid when I see patients in here. So how do we treat acne? Well, we start off on the skin using topical treatments. And the first thing that we want to do is try and get rid of that blackhead. So we use salicylic acid, which is a peeling agent, which you can get in washes or in creams. We use retinoids or vitamin A derivative, which you get in creams. Benzoyl peroxide, which some of you may have come across, which bleaches pillow bases and towels extremely effectively, but it's also quite good at treating acne. And another compound called azelaic acid. You can also use topical antibiotics on the skin, either erythromycin or clindamycin, and these usually look like a deodorant with a slightly spongy cover to it. And this is certainly where people will often start off with teenagers who have acne. We can also use combinations using antibiotics together, or using antibiotics with benzoyl peroxide. So we're treating both the inflammation with the antibiotic, and the benzoyl peroxide is dealing with the blackhead. And these are all various creams that people will come across. I personally prefer a retinoid plus benzoyl peroxide with Epiduo, or else Duac, which is benzoyl peroxide or an antibiotic, because they're better tolerated. But there are problems with topical therapy. One is you have to be pretty motivated to be using it once or twice a day. They often cause irritation on the skin, which people then just chuck in the bin. Sometimes people become resistant to it, and therefore it stops working. So in that case, we then move on to oral antibiotics, and there are a whole host of different antibiotics that can be used here. Personally, I prefer an antibiotic that you use once a day because that's easier for people to cope with in busy lifestyles. And I try to avoid antibiotics that can upset the tummy because understandably people don't like that. Medicine we don't use very often anymore because of the side effects. So the ones I use most often are either rinocycline or doxycycline on a once daily basis, and if that doesn't work, moving on to trimethoprim. Other treatments that we can use in women, or we can use in pills like rhotionium acetate or Dianet, because that has an anti-androgenic property in it, and I would have a very low threshold for using that in patients with polycystic ovarian syndrome for obvious reasons. We know the cause of women with PCOS is the high androgen levels, and therefore I would go straight to Dianet. But sometimes it's not appropriate for women to have a pill, particularly if they're older in age, they're very overweight, they have high blood pressure, they're smokers. We wouldn't want to be considering Dianet because of the risk of thromboembolus, deep vein thrombosis or pulmonary embolus. So there are other treatments that we can use. One is dapsone, and the other is spironolactone, which you've seen that name before, which we use in patients with hair growth. So if somebody comes to me with polycystic ovarian syndrome and acne and hirsutism, I'll be thinking of spironolactone quite early in my regime. Oral istradamine is controversial. It's one of the best treatments that we have for patients with really severe multi-cystic acne, and it works really well. It works in about 80% of patients. It cures their acne. The 20% that it doesn't work, it works in half. For one course, you have to repeat a course, and about 1 in 10 people it doesn't touch. The problem that I have is patients with PCOS, they will often respond very well while they're on it, but the moment they come off it, it flares straight up again. So I tend to avoid it in PCOS. And in fact, one of the reasons why I tumble to this is I often get referred patients to me by my colleagues who failed on istradamine. And the vast majority that I see of patients with PCOS haven't yet been diagnosed. And the reason why they haven't been diagnosed is they've come into the hospital already on the pill, so as you heard before, we can't do the hormone test for PCOS, so they get put on Accutane, they clear, the moment they come off it, the acne comes back. But it's quite difficult to ask women to come off the pill for 3 months while we investigate. So often I will do a trial of istradamine, and if they fail, then we need to look for underlying PCOS. And I will sometimes use Accutane in PCOS patients, having had the discussion that you may well relapse after one course, and we can't keep giving people courses of Accutane because of the side effect profile. What about diet? Well, I've had to change this slide over the years. When I first used to give talks on acne, I used to say confidently that acne had absolutely no role to play in acne, and it didn't matter how much chocolate or chips you ate, it had nothing to do with it. Well, we now know actually that's not entirely true. And the reason why this has come about is a very high incidence of acne in countries like China. And I think originally that was thought to be down to pollution. But then we started to see an awful lot of really severe multi-cystic acne in water. And they have a very, very high GI diet. One of the favourite national dishes is something called Nana's timpani, which is basically macaroni and cheese in pastry. And that's kind of the diet they have quite a lot. And not surprisingly, they have quite nasty skin disease and obesity and other problems. So actually, we do know that garlic doesn't affect sebum excretion rates, but that is some evidence that very high GI foods and a very high dairy intake can increase the incidence of acne. So I don't tell people with acne to go on a diet, but if they've come to me with PCOS, obviously we're encouraging a low GI diet anyway, and I also just mentioned dairy foods not to go over on milk and drinks. And we think that probably the mechanism for this is insulin resistance again. What about cosmetics? Obviously, if you've got really bad acne and bad skin, we want to cover up in the best way possible. But what we don't want to be doing is making matters worse. And one of the problems is a lot of cosmetics have grease within them. So it's very important that when you're looking at the labelling of the foundation or the moisturiser or any other cosmetic products that you're using, that it has the word non-comedogenic and oil-free, because up to 50% of cosmetics we use on our skin are not. So very important, non-comedogenic and oil-free cosmetics. It's the same with sunscreens. Very often people will notice if they do apply sunscreens on their face, which of course I'm encouraging people to do from the point of view of avoiding skin cancer, it causes an outbreak of spots. People often think it's the heat. Actually, it isn't. It's often because you've plugged follicles with a very oily sunscreen. So these oil-free moisturisers and cosmetics. So if you have got a new foundation, just try it on a sort of unobtrusive corner for a while and see if you get an outbreak spots. And if you do, stop using it. So what I've gone over here is the pathogenesis of acne and the types of grade of acne that we have. And the management really is exactly the same for PCOS as non-PCOS patients, except the use of dietary. And it's a combination of using topical treatments and systemic treatment, but not forgetting other factors. Just really to wind up now, what about the other skin conditions that you can get? There is a condition called acanthosis nigricans, and this is a thickened or velvety brown skin that you get in infections, characteristically under the arms. And it can be associated with skin tags, often asymptomatic, but in some patients it can be a little bit itchy, and sometimes if you get secondary infection, it can cause a nasty mouth odour. And this is due to insulin resistance again, and is responsive to weight loss. Hidradenitis suppurativa. This is a condition where you get very nasty boils and blackheads under the arms, in abdominal folds, if you're very overweight, under the breasts, and in the groin between the legs. Some people call it acne inversa because it's a form of acne that you get where you don't really get the acne. And it's where the apocrine glands are as opposed to the sebaceous glands. It's much worse if you're overweight, and that's because there's friction of skin and skin. And whilst PCOS patients don't often get this, there is a higher proportion of patients with this condition who have PCOS that don't. You get boils under the arm, in the groins, and under the breasts, but they're sterile. So if you take a swab from them, they don't grow bacteria. You get bridging comedones, which is the pathognomonic sign, which is where you have two blackheads with a bridge of skin going over it. And that's absolutely pathognomonic. What can we do about it? The main treatment actually is weight loss. So I always encourage patients to go onto a low GI diet, and also to have at least 3 episodes of half an hour cardiovascular exercise a week, which helps increase your sensitivity to insulin and therefore will assist with weight loss. Metformin can be helpful in this instance. Although there are no bacteria within the boils, we do use antibiotics. Well, why would we do that? The reason for that is antibiotics don't just act to kill bacteria, very often they are anti-inflammatory. That's often why we use it in acne as well. So we will use rotational antibiotics, moving from one to another over 3 or 4 months to try and prevent resistance occurring. The oral contraceptive can be helpful, and again, we believe that's probably because of the anti-androgenic action. Vitamin A-related drugs called retinoids can be helpful. Sometimes if you've got very, very inflamed sore lesions, and I get patients coming up to my clinic who can't actually sit down and it's so painful because of boils, or they can't lift their arms over their head to comb their hair or put on the top. Giving them a short, sharp dose of oral steroids can just get them a little bit pain-free, and sometimes we'll inject steroids into the boils, which helps them resolve. And there is a drug called biologic or immunotherapy that we can use in patients with very severe disease. So in summary, what are the skin problems that we get in polycystic ovarian syndrome? Acne, too much hair, too little hair, and boils. And where I finished quite probably, but I did start early, so it gives us plenty of time for questions a little bit longer.
Aren't we so lucky as women with PCOS? So again, please just put your hand up if you have a question. And Chris is coming with the microphone. I can't believe there isn't one question. You go to the back. Yeah.
That's very difficult. And the reason for that is because really any treatment could have an impact on your baby. So the simple answer is really very little, except topical erythromycin and zinc is the one I would use. You can't use retinoids on the skin topically, you can't use methyl oxide, you can't take all antibiotics, you can't obviously be on the pill. So really the only one is topical zinc. Fortunately, well, what if you have managed to conceive and you are pregnant, the acne will often resolve. So if people are actively trying to conceive, I would try and get them on all treatments. If their acne is really bad, you can be on an antibiotic. And I would use something like erythromycin, which is the safe ones. You can't use trimethoprim because that's antifolic acid, so that's somebody who's trying to conceive young trimethoprim. You could be on doxycycline or minocycline, this is a tetracycline with antibiotics. At the moment, you are hoping that you have to stop that because it gets laid down when babies with the teeth that are developing. So you can't be on a tetracycline, but you could be on erythromycin if you absolutely have to be on something. But topical is in it, is the same.
Over here. Yeah, and then in the middle.
Hi, I tried the benzoyl peroxide and it just ended up drying around the spots and didn't have the actual spots. So then I put on tetracycline, which was brilliant. I had to come off that because I became pregnant. And the spots did clear up, it was wonderful, but I've noticed they're starting to come back now with a vengeance more on my back and arms. What would be, because I was told you have tetracycline, you can't really go back on it. I was put on it for 18 months and I was told that that was too long to be on it, that I should have only been on it for about 6 months and then come off it if it was going to work.
No, I mean, if you've got an underlying reason why you've got your acne, there's no reason why you can't, in fact, you need to stay on longer term treatment. There's no reason why you couldn't go back into a drug you had before, particularly if you've had 9 months off it. The worry about going back onto an antibiotic you had before is antibiotic resistance. So the most important thing is you can go back onto whichever antibiotic you tolerate. Personally, I don't use oxytetracycline because you either have to take it twice a day or 4 times a day, and it has to be on your empty stomach, and that's actually incredibly difficult with a normal lifestyle. So I prefer minocycline or doxycycline, which is once a day, which is much easier to take. It doesn't matter whether it's an empty stomach or not. But you must use a topical as well. And the reason why is that if you don't have a topical treatment as well, you will get resistance. Right. So what I would suggest is if you don't get on with benzoyl peroxide and you have to try something called differin, which is a retinoid, it's called a dapiline, and you start off short contact. So the size of a pea goes onto a hand's worth of skin. You start off for an hour and then wash it off. You then leave it on for 4 hours and wash it off. And then when you've got used to that, you can then start leaving it overnight. And that way you'll build up tolerance to it and you should be able to tolerate it. Really. Thank you.
In the middle.
I was diagnosed with PCOS, and you said that underlying cause of acne is elevated levels of androgens. My testosterone
Or
levels-
sensitivity to it, not necessarily an absolute.
Right. So if my testosterone levels are right,
Yeah.
so I was wondering why I get acne.
Yes, I mean, basically not everybody with acne has raised levels, but it is due to the androgens in the skin that we get acne. So teenagers don't have an abnormally high level, but nevertheless they still get acne. So acne is due to androgens, yes, but not necessarily an abnormal level of. So for example, the reason why you get acne around the time of your cycle isn't because your testosterone level's gone too high, but it's because the body thinks it has. So it's either end organ sensitivity to or an absolute raised
So
level
is
of.
there a way to desensitize body?
To desensitize it, yeah. So you can suppress the absolute levels, or else you just have to treat the other effects of. So we do use anti-androgens to reduce the absolute level of, which is why we use certain pills, why we use spironolactone and treatments like that to actually reduce the absolute levels of testosterone, or you treat it the other way with anti-inflammatories and things to reduce the levels. But no, not everybody with acne has an absolute raised level of androgens at all. And of course, it's not just the testosterone, it's also LH. And a lot, not all, but a lot of PCOS patients will have a slightly raised level of LH, and that can be what's causing that.
Hi, so I take Dianette for my skin because I get very bad skin acne, basic facial acne. But I've heard that if you come off Dianette, then you get worse acne, and also are there any risks associated with staying on Dianette for a long amount of time and don't just stop after a certain amount?
Okay, that is an absolute hornet's nest that you have just gone into. The first thing is yes, if people go onto Dianette and they come off it, there can be a rebound flare of the acne afterwards, which is why there are some acne specialists like Professor Chu, who I trained under, and he does an awful lot of the acne support with into Dianette, because when people come off it, the acne can suddenly rebound quite badly. But nevertheless, Dianette is an extremely useful drug in PCOS. What I don't personally like is treating acne in people without PCOS and Dianette. And I think you need to have a diagnosis before you put people on There's nothing you can do about that except when you come off Dianet, for whatever reasons you do, just be prepared for that and don't try and sit it out. If your acne is flaring, go and get help sooner rather than later so you don't get scarring. And there are ways it can be treated. In terms of can you stay on Dianet, there was a huge scare about Dianet and people remaining on Dianet because if you force feed cyclosporine acetate to rats where they have like 3 times their body weight in Dianet, they will get liver cancer. Of course, that's not the kind of dosage that humans are taking. It's, you know, we're taking a tiny proportion of our body weight. That scared the medical profession. The other problem with Dianet is it's got a 3-fold increase of deep vein thrombosis and pulmonary embolus. And therefore, there's just come out actually a new screener for GPs to use as to whether patients are safe to go onto it or not. And it certainly would be risky in somebody who's very overweight, particularly if they have high blood pressure, particularly if there is a family history of deep vein thrombosis. But if you're slim and a non-smoker and you don't have a strong family history, there's no reason why Dianet can't be started. But of course, that does exclude a lot of people with PCOS, so it can be quite difficult. Also, you don't want to use it in people who are older. So I would be really concerned about using Dianet in somebody in their 40s because of this risk of DVT and the other exclusion to it is if there is a family history of early breast cancer, but that's actually something that we consider with all panels anyway. So there is now a much clearer pro forma as to who can go on it and who can't. It used to be said that if you're treating acne with Dianet, which is its licensed indicator, which is not licensed as a pill, it is licensed to treat acne, that you treat the acne until it goes and then you come off it. But we've just said as soon as you come off it, your acne flares again. So that's not actually realistic. If you don't have PCOS, you will sometimes get away with that, and then you can use something like Yasmin or Cerazette instead. But my usual experience of people with PCOS is the moment you come off it, it flares again. And I'm very happy to leave somebody without any other risk factors on Dianet for a long time, as long as they understand the risks. What I would also say is if you're about to have a long-haul flight, possibly consider coming off the Dianet for a couple of months, taking an aspirin, using deep vein flight salts, drinking plenty of water and no alcohol on board the flight. So just using sensible precautions if you're going to put yourself in that kind of situation. But no, there's no reason why you need to come off it after 6 months.
A few years ago, I was talking to a doctor and she was saying that the best pill she got would be Yasmin. But then she said, I'm going to get in big trouble because it's really expensive and I'm not supposed to prescribe it. But she did anyway, so it's fine. All the pressures. But with a lot of things we've talked about, so like the Nika or the laser and electrolysis, do you think there's a case for more money to be made to make that available for people? Because at the moment, as far as I'm aware, you can spend a lot of your own money on these things.
Yeah, sure. I think none of us will have escaped seeing what we've seen in the press over the last week of the dire situation that the NHS is in, and quite simply the NHS is on its knees from the funding issue at the moment. And GPs are under huge pressure to control their budgets, and unfortunately what is happening is so-called soft treatments, treatments that aren't for life-threatening diseases are not being funded anymore. So that's why I said you may get value covered, actually in reality most people won't. When I started my PCOS clinic, I used to be able to get people electrolysis on the NHS, Valical on the NHS. We had more or less freedom of what pills we could use. It's a very different environment out there these days. And no, unless you happen to have a GP who's sympathetic to PCOS, you may well find that they will say, no, it's too expensive. But that's not PCOS that's signalled out. It's the same for people who have high blood fats and they always get put on the cheapest, which is actually the one with the most side effects. So if you have high blood pressure, you go on the cheapest. And it's the pressure that our family doctors are under to try and keep their budgets under. In an ideal world, yes, of course, everybody with PCOS should be able to get laser and electrolysis funded, should be able to get Dianet or Yasmin, but that's not the real world we've got out there these days, sadly. If you're needing it as a contraceptive, you usually get away with it. But,
I just want to ask a question. It's for one of my friends from my local group. Can you get electrolysis on the NHS?
I think simple answer to that is basically no. It's area dependent, and there are some CCGs, clinical commissioning groups, where the GPs purchase healthcare, who will provide that in that setting to an endocrine clinic, for example. In my area, I haven't been able to provide it on the NHS for about 10 years. And increasingly, various conditions are being struck off the list as to what they will treat. And it's not something that my area will treat at all now. The simple answer is probably not.
Do you remember the web link I gave you earlier? projectpcos.org.uk. This is entirely relevant to what we're trying to do, so please go and visit that website. Next question.
Coming back to Dianet, I was on Dianet for 15 years. What's in your opinion, the upper age when it's safe to take it?
I think it's 35 is the cut-off. Stop before you're 35. They've literally just come out last week, these new guidelines, and I think it's 35.
Okay, I'm 32 now, but let's say I'm 35, what do I do next?
Very good question. If you need the contraceptive and want to be on a contraceptive pill, then there are other less risky ones. So something like Cerazette is less risky, even Yasmin is less risky. But any pill is riskier as you get older. So it would depend on other things like whether you're a smoker or overweight or high blood pressure or the other things. And everybody will be taken on an individual basis. If you need the anti-androgen for hair growth or acne, then spironolactone and an alternative method of hormone treatment, of contraception. Depends whether you've had children or not. Sometimes the coil can be a very good form of treatment for use for contraception, and we can choose ones that don't make acne and hirsutism worse. So it's individual on what the individual requires, and every patient and every PCOS patient will have different needs depending on what their major symptom is. But there are other things out there.
And yet about plasters, are they
Patches, the implants. Yes, you need to choose a progesterone-only one, and you need to use one that isn't an androgen that can make matters worse. So some of the implants can have a progesterone in it, which has male-like properties, and obviously that's just going to make matters a whole lot worse. There's one called Nexplanon, which has an anti-androgen within it that isn't too bad for people with PCOS, and that's the one that I would usually recommend, Nexplanon.
Any more questions? At the back and then at the front.
Hello, I suffer with excess hair and acne. What is spironolactone and how does it work?
Okay, spironolactone is a diuretic. It's a tablet that we used to use to treat people with high blood pressure to make them pass water more, which is one of the treatments for high blood pressure. And as a side effect, it was noted that it had an anti-androgenetic property. And I'm not quite sure exactly where that comes in, but it has an anti-androgenetic property within it. And therefore, we are now using it in people with PCOS for the hair growth and for the acne. And we use it at lower doses than you use as a water tablet. So we use it in doses starting off at 25 and I go up to about 100, whereas if you're using it as a water tablet, you use it at 200 milligrams. So it's acting as an anti-androgen as a side effect of its main licensed use.
Would it be safe to use as my blood pressure is on the low end of normal, as in too healthy?
It might not be, you may get symptoms of dizziness. But you can start off on a low dose. So, I mean, if you don't have symptoms of low blood pressure, and they start you on a dose of 25 milligrams, that's not at a dose high enough to cause low blood pressure. But it might limit how high it can go up. But that wouldn't put me off starting you on it. So we don't just use it in people who have high blood pressure, but I would start low and try it. If you've got symptoms of dizziness, it would have to be stopped. But I've never had to stop it for that reason. The reason I most often have to stop it is because of headaches.
And just a quick one. Just I've recently been diagnosed with an iron form of vitiligo. The consultant said that he wanted me just to have like a blood test mention for the thyroid. And the only reason I would be mentioning about thyroid and iron, could that be connected to anything, or is that just completely?
Okay, the reason why that's coming in is because hypothyroidism and vitiligo are autoimmune conditions, which are also linked with type 1 diabetes. So there's a whole load of them, but they're all autoimmune conditions where your body's immune system is fighting off your body rather than the cold. And if you have vitiligo, we always look for or thyroid antibodies, and pernicious anemia, vitamin B12. It's not linked to PCOS at all, but if you have oligomenorrhea, you have very, very long cycles, or you have hair loss or hair growth, that can be due to thyroid abnormalities as well, and that's why we would check it, but there isn't a link. Thank you. PCOS is complicated enough without
Hello. Would the marine coil help? Or would you...
No, sorry, I can't see who's asking that.
Yeah.
No, I hate the marina coil, I'm really sorry. And the marina coil often causes acne, in my experience. So I personally don't like the marina coil. And people who present to me quite often with worsening acne just after they've had a marina coil fitted. So another coil, but not the marina. And the reason why is the marina's got a hormone within it that can make that as worse.
Okay, what about the hair growth?
It can make that worse too. Yeah, because it's got a progestogen in it that it's a hormone that it secretes that's male-like, so it doesn't help.
And yet this was implanted by a
Who has an interest in PCOS?
who knew about this.
I knew about PCOS. Yes. I think, unfortunately, in the medical specialties, there often isn't joined up thinking. And I think PCOS particularly is one of the conditions that suffers from that, because you have symptoms that go across endocrinologists, diabetologists, gynecologists, and dermatologists. And not everybody has joined up thinking. And it's one of the reasons why I started in my trust, that the gynecologist, the endocrinologist, and I all got together and all agreed how we were going to manage our patients. So whoever somebody came into, we were all talking from the same hymn sheet, and we were all doing the same thing. And I think one of the problems that you guys suffer is going from one person who tells you one thing, another person who tells you another thing. And a gynecologist will fit the marina coil because it's brilliant for controlling heavy periods, and it's a really good substitute when you need to come off the pill at a certain age, but hasn't clicked that in a lot of people it can make acne, and it doesn't matter whether you have PCOS or not, it can make acne and hair growth worse. And that hasn't clicked because they don't see the people with the acne and the hair growth.
Right, so basically we need to look for a coil without any progesterone.
Without any hormones in it, yes.
Yeah. Thank you.
And I have the same actually with people who are put on the pill. A lot of people are put on the oral contraceptive pill, and they're usually put on Marvelon, or one of the other ones containing norepinephrine, which is dreadful as far as I'm concerned for acne. And so people unwittingly have been trying to help, but actually making matters worse. So I always recommend Cerezet's the main one, just if you want to remember one name. Cerezet's the main one that I use that has a non-androgenetic progesterone, which is quite helpful for people.
So I've been on spironolactone before, but I got the side effects of headaches that you were talking about before, and I had strange potassium levels.
Yeah.
Are there any anti-androgens that don't have this side effect, or that you could try that might not give that side effect?
Finasteride is another one that you can try. Finasteride. Also anti-androgenetic pills like the Dimet, or additional cyclosporine acetate on days 5 to 15 of the cycle in combination with Dimet is something else that can be used. But that would depend on individual circumstances. So yes is the answer, there are others. But those are the most common side effects of spironolactone, which limit how we can use it.
Okay, thank you very much, Dr. Mann. So we have tea and coffee ready out here, and we also have Nikki in the audience. If anyone is interested in learning more about laser, there's a stand out in the foyer, and we'll break until 22 and then come back in. Okay, thank you. Interesting.